nearly as much work in understanding the systems. Now, here's the thing. There are common diseases. Just take some time, Google it, figure out what it is. Because one of the things you have to know is you need to know how medication is going to impact. What are the side effects from medication? What is the, what course of treatment would look like? What's the prognosis? So for type 1, you kind of know what that is. If they adhere to treatment and they kind of stay on track, then the likelihood is less that they'll experience these other complications as they get older, right? That's what we're hoping. The same thing would apply to cancer. I actually did my training at Duke, at their Comprehensive Cancer Center. And so that was a completely different experience because, I mean, I dealt with people from they don't know to palliative care, right, and end of life. So ran the gamut. But there were still some things like I didn't necessarily know, I didn't have to know everything about all the cancers, but I did GI cancers. So even at that, could I tell you what the name of the cell was? No, because they don't really care about that. The thing that they would like to know that you know is that when they're talking about it, that you have a sense of like, so where's it located in the body? What is actually going to impact, so if somebody's getting radiation treatment, what is going to be the side effect? Can you stomach seeing somebody who has an ostomy bag? Can you be present when maybe some things didn't quite go right with the ostomy bag? Like sometimes there are accidents. Like there are different things that they need to know that you can kind of like be okay in that medical environment because your patients could be doing therapy with you and they could have an accident in your session, right? Or something could happen. And so having like more of a general knowledge, I think once you start to decide what you want to be focused on, that's where you start to develop the depth of what you're going to do. So you kind of have to be kind of broadly knowledgeable. So knowing like hypertension, diabetes, heart disease, MS, relative different forms of cancer, but not necessarily knowing very deep specifics, but just kind of having a general knowledge of that. Some GI disorders. So it's like you can kind of look at what is typically seen in your clinic and then kind of go from there and do more depth. Now the spiritual piece, I found that when people are experiencing chronic disease and illness, that they usually have a spiritual perspective. Now, maybe it was different because I was working with cancer patients, but almost everyone that I talked to when I would ask them how they've been coping, that was the thing that would always come up. It's like, well, I pray, or I have people pray for me, or my spiritual community, or whatever that might be. When I think about myself, and I think this is often a place where therapists kind of get a little skittish, for lack of a better word. I am very comfortable with my own spirituality. And I think I got to that place when I actually started my master's program, because as a person who identifies as Christian, my pastor was like, well, there are going to be certain people you can't see. And I was like, okay, I'm not talking to you because you don't know. But I could say that. That was what was happening in my head, right? So I had to get to the place where I was like, so how am I going to make sense of this on my journey? And the thing that I thought about was that I knew that I was called to be a therapist, that was what my job was supposed to be, that was it. Took a kind of an interesting route to get there, but yeah, when I realized it, I was like, oh, that's what, okay. So I saw how all the things kind of fit together. And so with the understanding that if I say that I was called to do this, when I was called, he didn't say, oh, well, you're only going to do therapy for this group of people. I didn't hear that. That wasn't the clarification I got, right? So it was like, you're going to be a therapist, right? So he didn't say only for Christian couples or Christian families. So there were no caveats on it. So whoever I engage with is who I'm supposed to see. Now, doesn't mean that I leave that at the door, because if I say that I'm a spiritual person and that I pray, well, before you walk in, I'm going to be praying. You could be sitting here, and I'm going to be praying. When you leave, I'm going to be praying for you. When you cross my mind, there's a reason why you cross my mind, and I'm going to say a prayer for you. Doesn't mean that I don't do something with my spirituality. Now, how does it enter the room? I always check with my clients and patients about their spiritual needs, right? Just because you identify in the same way that I do, doesn't mean that I'm like, oh yeah, that's right, we on the same team. No, we're not, because this is not, I'm not proselytizing right now, that's not my job. No, I'm a therapist. So, I ask the questions about how you use spirituality as a support. And they could ask me, and I'm okay with saying, yeah, I do. And so, how is that important for you to know that that's what I do? How are you making sense of the fact that, why do you need to know this information about me? I had clients ask me, especially when I was working at the Cantor Center, they would be getting ready to pray. You know, and so I was like, okay, well, I'm going to step out. And they were like, no, will you stay? And I said, okay, all right, I'm in. And they're like, and we're going to all in. So I said, okay, all right, here we are. So I'm praying. I mean, clearly, I'm not leading the prayer. But I'm listening. And, you know, for me, I'm like, oh, I can be in agreement with that. Okay, all right. So, and I was fine with that. You have to get to the place where that's what you're fine with. It's just like proximity. Right? This is the first place I had a challenge around somebody being in my personal space. What do you mean? Therapist on no, that's not what I do. Somebody's grandma. I spent some time with her, and she goes, you know, this has been so nice. Can I help you? And I thought, oh my gosh, how do I say no? Oh wait. Okay. All right. And I was like, I gotta think about this. Like, what does this now mean? Because I hadn't had kids yet. Hadn't had young kids. If you get young kids, that's like trial by fire. They're all over you, like. So, I mean, but for that, it was like, I mean, because sometimes we don't really talk about why that could actually be therapeutic, how it could be therapeutic. And you know, when you're somebody who is challenged about your own space, then you're like, oh, no, I don't really need anybody in it. And yeah, I want to help you, and I know I'm a therapist, but it doesn't mean that I have to be that close to you. I don't have to do that to help you, right? And so it meant that was some self-therapist stuff that I had to work through. Like, what was that about? Why did I think that as a therapist I couldn't offer therapeutic closeness, right? And what did that mean? I think when you're in a medical setting, you will probably be more apt to encounter people, depending on where you are. If they are, I mean, for some of these families, if you happen to be on call and the child is coming in with what they call a DKA, that's usually what the precipitating event is when you get diagnosed with diabetes. It usually requires an ER stay, a extended hospital stay. That's like a really scary time, right? And so you got parents or whomever the family members are in there, and they are just like they don't know what to make. They don't know how to make sense of it. They're scared. They think their kid might die. Like, that's some serious intensity, right? And there could be that, like, people could be crying, they could be visibly upset, and so you kind of got to figure out like how you're going to locate yourself in that space and like what you're comfortable with. And it's through experience, I think. Ask your clients, what meaning do you have around it? Because it's part of the same check-in that you do, right? It's always, if you're gonna do MFP, that's always part of what you do. That's always part of what you attend to. That always has to be, because even if you got your own little notes, it's like, check, did that, check, did that. Like, you have to make yourself go back to that and check in with all your clients. And it's not like, if you happen to miss it, you run out of time, you go back to it the next time. You say, you know, I was thinking, we talked about this, we talked about that. I'm also curious about this. How does that fit in your life? Oh, it doesn't? Okay. Then that's the end of that conversation if it doesn't fit, right? But it's like, it's not I don't view that as like an affront to me as a spiritual person. Like, oh, what do you mean? Like, that would be so amazing if you could connect. No. Staying in the lane. I'm a therapist. I'm not trying to convert you. Two totally different things, right? Now, what that might look like, if I said I was a Christian therapist, might look very different. But that's not how I identify. Any other questions? Yes.
I have a question about the point, increasing sensitivity in the parent and the patient and family.
Mm-hmm.
So, I think my specific question is about siblings, working with siblings. If you have family members, maybe parents, but siblings who might feel victimized by the patient's illness, like feel like they're burdened without acknowledging the privilege of health, but you're also trying to increase the sense of agency in giving patients more opportunities to take ownership of their diagnosis, their disease. Would you ever involve siblings in helping with like the medical pieces of treatment, or like, I don't know, just to, I don't know, maybe empathize, but also like help them understand the privilege of their health so that they don't feel victimized by that?
I would. The way that I think about it is oftentimes siblings become de facto providers. All right? My brother was 10 years younger. Where are you going? Take your brother with you. What? So if anything happened, I had to know what to do, right? And I think when you've got something like type 1, having to know what the signs are when their sugars are low and when they're high, what you should do. It's actually being able to provide the balance between what's developmentally appropriate and what is necessary. Because oftentimes if you've got a single parent and they've got other kids, the other children might have to do more things to be able to help out the parent, right? But I'm all for psycho-ed. Like you can't, okay, so I shouldn't say that, man. It's unacceptable, people do it, but you should not include the family. Like if they are siblings and they are going to be responsible, and I wouldn't stop at siblings because guess what? If they're at grandma's house, I mean, see grandma too, grandpa, great aunt, oh, you just, who is gonna have hands on this kid? Who are they gonna be, whose care will they be in? Whether they're walking home from school, whether they're in school, or they're, walking into Nana's house, or whatever it is. Like, I wanna know who all those people are because they all need to have some level of psychoeducation. And oftentimes what happens is that parents end up doing this, or not, because it becomes too difficult. And so they say, you know what? You just come to my house. I'm not sending my kid to you. No, just, this will be party house with you kids, because I don't want to have to trust the care of my child to somebody who might not know what to do. Because we're not talking about, oh, you slipped and you got a skinned knee, you put a Band-Aid on it. Like, no, this is way more than that, right? And so sometimes parents can draw back because they want to protect their children, and to say, well, no, I'll just do it. No, we got it, and we'll make adjustments, or we'll bring what we need to bring, and that kind of thing. So the thing that makes the most sense is to be able to give the siblings some sense of control, and also talk to parents about how do you balance out care to your kids, because sometimes, depending on how grave the issue is, sometimes it feels like, I know I should be doing this for my other kids, but like, this is so heavy that I know I have to attend to this, and then my other ones are like, so like, how do you balance it? And so giving parents really the space and giving them some ideas that are very easy to implement around how do you provide a sense of specialness to your other kids. Like, there was this one, and I can't remember where I saw this, and I thought, that is such a fantastic idea. So you make the day of their birth their special day every month, right? So I'm born on the 13th. So on the 13th, whenever that falls, so I could say, well, what if it falls in the middle of the week? And they're like, well, we can't. No, it's not about like, let's go out and do all this stuff. Maybe I get to decide what we're having for dinner. Within reason. Like, you always have to give, like, options. So, okay, what are we having? Spaghetti, lasagna, or whatever. You get to choose, right? Or if it falls on the weekend, we have some activities that we had planned to do. Or we're gonna have an in-house movie marathon. You get to choose what movies we're gonna do because it falls on your day. And when you have 2 or 3 kids, just something as simple as that makes them feel like I'm seen and I matter. Like I've not been left out. Because when a child in the family is sick, it can feel like all of this attention is heaped over here and my life has to shift to accommodate whatever's happening over here, and that I might get more responsibility and I might not feel like I get a break. And you still expect me not to complain about it, right? And it's like, come on, they're kids. Like you gotta get them in that space where they can actually get the support they need to. I think having SIB sessions would be fantastic if there's a group. So like kids who have type 1 have their siblings in a SIB group, so that the SIBs can talk about what it's like to live with to have a sibling who has type 1. The parents need a group, the grandparents, anybody who's a caregiver. Like those kinds of things are something that I would hope that the center would be able to offer for families, so that they have a space and a place, and so that the siblings know that their experience is valued too.
My question is, how often have you been able to work with perhaps child life specialists with collaborative care?
So, interestingly enough, we didn't have child life specialists, which I thought was interesting. It was just a therapist. So they didn't do child life. Now, it was based on how our program was developed out. It was developed for therapists. So I think what I know of their profession and what they do, both from personal and professional experience, their goal is usually medically directed around medical play and helping children understand, so if they're hospitalized, helping them have a safe space to have playroom. If they're going to have a procedure done, they'll come in and they'll have like a little doll and they'll say, yes, you're gonna get an IV and this is where it'll go. So they do that kind of thing, but they're not therapists. So they might be able to provide some psychosocial support. So I think you could partner well with them, and if they saw something when they were doing the medical play that they would then be able to pass that information along to you so that you could say, oh yeah, so we need to be more thoughtful about this, and maybe this kid is more anxious about this piece, maybe we need to do something to offset that. But skill sets are somewhat different. Yeah.
Do you ever find it necessary to do brief work with the parents with, sometimes with certain chronic illnesses, it's, like you've been talking about, families shift in a lot of different ways and what their expectations for their child have shifted, and it's an exhausting process, so I was just wondering how that plays into your work.
So definitely it plays into the work. When I did the bulk of my work, I didn't have them for a long period of time. That would definitely be something that would be part of regular sessions because it's the same, you're grieving the loss of what you thought your child would be. And it's not like, they're not gone, they're still here, but their health has been challenged, right? And so it's still that piece of, because one of the things that young women who have type 1 have to be concerned about is being able to get pregnant. Because it takes you have to be well controlled. And doctors are very adamant about that. They're like, no, you don't need to. Don't think about having kids. And it's like how then do you make sense of that? If you're a parent, you're like, wait a minute, I want to have grandkids. What? So then you not only the loss of what you were hoping for your child, but then what you thought about grandchildren, what would happen after them, right? So there is this piece that goes along with that, and I also think that you have to think about where parents are, what other losses they've experienced with their own families around health, because that can actually start to come up if this is a new diagnosis for them, with their young children.
I've been wondering about appropriate dosage and not doing that as a way of self-harm. What sort of things around that?
So you have to be aware of what's happening because adolescents learn quickly that they can use insulin to lose weight. And so it's almost like, like I had said, like you have this checklist. So that's something that you should always assess for and make sure, because here's the thing, that you don't have to be taught how to do that. You figure it out. And, kids are very smart that way, right? So they figure it out, and then they will self-administer too much, that kind of thing. I think I think a couple of things. So I think when you are seeing them regularly, that you have more insight as to what's happening. I think oftentimes that those kids are not being seen by a therapist on a regular basis. This is kind of more, for lack of a better way to say it, like it's newer, that there would be a therapist embedded or somebody who provides psychosocial support. And so oftentimes when medical professionals think that's happening, it's been happening a while, right? And I think if this were the case now, so if you were a mentee and you were there, it's just a way of assessing, asking certain questions about how they dose, when they dose, those kinds of things, that you can get a sense of like, okay, we're gonna have to check this out. If they had you could even do like how much insulin, are they running low on insulin? Are they needing to refill their scripts sooner? On their pump, the pump can be downloaded. So what they administered can come up on a printout. So you can look at those kinds of things and see, like, this seems to be a bit, we didn't change your dose, but you're dosing pretty high for this, so we need to talk about that.
What about the opposite with maybe not doing it so that there are harmful effects to the bodies, that you're not dosing enough? I don't know if that's helpful.
So, I don't think that I don't think they would not dose to produce harm. I think they would not dose because they are tired of it. And that the consequence is harm. Because if you think about a kid who like might be 14, 16, 18, and they were diagnosed very early, 18 months, 2 years old, they've been doing this a long time. And they just get tired of, they're like, I'm just tired of being sick. I'm tired of having to do this. I'm tired of always having to watch what I eat. I am just sick and tired of having to monitor. I'm tired of people asking me, don't ask me anything about it. Just leave me alone. Right? So and that's why adolescents tend to be less compliant. Because they're like, this is not my life and I'm just really sick. Okay, so what'll happen if I stop? What? I don't care. Whatever. Right? And it's like, okay, wait a minute, you have to care. Come on. Like, no, let me get you back on team, Isha. Come on. Like, no, we have to care. But how do you not relate to that? That you're like, if somebody asked me one more time about that, like, this is not the totality of my life, but it becomes, right? That before, when you go into the doctor's office, just like how I said, my doctor says, how are you? Their doctor is like, okay, so your A1C is, like that's how we start our conversation. It's like, I'm more than diabetes. But oftentimes that's not how it goes, right? Other question? Yes.
I'm wondering if you could speak a bit to like power dynamics relative to like say like diabetes or just like within medical family therapy, because I'm thinking of like a woman I worked with where like someone was checking her sugars while she was sleeping, like to ensure that she was taking care of herself, or just different things along those lines.
So power dynamics within the family system, or both with the family and the medical?
All of it.
All of it, okay.
It was a lot.
So when you think about adolescents and where they are developmentally, what is really the only thing they control? Themselves, right? So, and this is why sometimes they struggle with eating disorders, right? And behavior. Okay, so no, I know I can't do that, but I bet you I know what I can do. I'm gonna do this, and what are you gonna do? Nothing. Because what you can't make me, right? And it's like that's the worst position to be in a power struggle around this, right? Now, does it mean that it doesn't happen? I think part of preventing the power struggle for adolescents is starting earlier and around how you do continual check-ins across time. So if they started out, let's say they were diagnosed at 4, developmentally there's some shifts that happen, right? So when they start school, there's something that happens. When they go to middle school, there's something that happens. When they go to high school, there's something that happens, right? Or junior high, let's skip that one, junior high. So it's almost like doing well checks, right? Do you have the coping skills that you need? These are some pretty good ones. But guess what? Things are gonna shift a little bit when this happens. Because what else happens in adolescence? Puberty. The hormone shift throws off blood sugars too. So it's like they can't win. It's like internally they're having this dialogue about like, I hate my life, and then their hormones are saying, yes, you should hate your life, and it's just like, they're just like, what is happening to me, right? And then you got parents who don't seem to understand, the medical professionals don't seem to understand it, and they're just like, okay, fine. I'm just not doing it. What are you gonna do? And then of course the parents get super activated, right? Because typically the parents who work best for helping kids with type 1 are either authoritative parents, authoritarian parents. Now you might think authoritarian parents, like, really? Oh no. But you will be in control. right? They're the ones who are rigid. It's like, it's all about rules and regulations. But yeah, that's important when you need to dose. However, what tends to happen with kids who have those kinds of parents? As soon as they get a chance, they're just like way left, right? But then when you've got the authoritative parents, you know, those are the tender parents, right? They're like, oh, we love you, and we're giving you boundaries because we love you. And structure, right? So of course these kids flourish in environments like that, but you also have to think about culture. What does the culture dictate around parenting? Do I need to be rigid to protect you from what's happening out there? Because if I'm saying, oh yeah, go out there, explore, that might not be a good thing. I need you, when I say be back, that's what I mean. There's no, this is not a democracy, no, it's a dictatorship, right? Because I'm responsible for you and I want you to be safe, right? So it's like trying to find the balance around what is going to be appropriate for that family and expanding their skill set around what things are up for negotiation and what things aren't, right? Because if I give you some space to make some decisions, then you're gonna feel like you're doing something, right? But if I never give you space, and so that's what happens along these checks. So it's both the kids and the parents, because I gotta teach the parent or parents, okay, now you're gonna have to modulate how you engage your child. Yes, they're about to go to junior high. Right. So like, what are the consequences you now have for misbehavior? Well, I mean, they get sent to their room. They get the Game Boy tape. Really, is that going to do what you wanted to do? They really want to go to their room because they don't want to talk to you. Is that punishment? No, the punishment is, guess what? We're sitting on the couch. You're right here. Hi, how are you? Good to see you. Because I know that's the last place you want to be, is sitting on the couch next to me as mom, right? So it's like, how do you shift what those consequences are? What might be better natural consequences? Oh, I'm not having a discussion with you because you broke curfew. You already know what the rule is. You don't, I guess, we don't have to worry about where the car is for the next 2 months. Yeah, and it's like, why are we debating it? So it's like the ways in which you structure how parents engage around her. If you get them early enough, then you help them shift what those look like. Just like the coping skills, right? Doesn't quite what works here, we're gonna turn it this way so it works better as your child ages. Now in the medical profession, you know, doctors can be kind of territorial because that's my patient. You can't count the number of times that's been said. No, my patient. Okay, yes. I'm not going to debate. Yes, that's your patient. I mean, I think they're our patient, but okay. But it's more around if my patient is not compliant as a reflection of me, which then means I'm not the doctor. And I will not have anybody say that I'm not a doctor. So you do what I say you do, right? And so they can get very like rigid and like, no, you need to do this and you have to do this. So if you're talking to an adolescent, it's gonna be like, your mouth is moving. They have turned you off and they're like, or, I don't have my phone. So then they're in there and you're like, okay, you lost them. And I don't know whether you have kids or not, but okay, note to doctor, when they do that, you've lost them, right? So as a MFP, you can actually intervene and help the doctor use himself as the doctor. I'm not joking. Because they don't see it. It's like, so when you say, so, I was just watching this interaction and I'm just wondering, like, have you ever had any problems like this before? Well, what do you mean? Like, well, this. And you're like, well, I've never thought about that before. Well, just think about it. Could be that they're responding to you as they would respond to their parent. And you see that they're really not getting along with their parent right now. Because everything that the parent says, they do the opposite of. So you're actually in the same position. So they actually might be thinking about you as an extension of their parents. So that might be why. I'm just saying, you know, think about it. You think about it, let me know what you think. I don't ask for like any definite change in character. No, no. I'm just wondering, you know, I was thinking about that. Could it be? What could it be? You don't always have multiple things it could be, right? And you throw them out there. If you know your doctor well, if you work with them long enough, then you can tell. You can say, you know, the thing about power, do power struggles actually resolve anything? I mean, in my experience, they really haven't, but I mean, I don't know if you feel like it has, but you know, they haven't for me. But just kind of like giving them just enough information to help them go back and think about it later so that they can do a little bit of reflection. And you can always check in with them, you know, and say, you know, I was thinking about that conversation we had the other day. Was that helpful? Like, did any of that, you know, make sense? And then, you know, begrudgingly, they might say, well, yeah, I thought about that. Oh, okay. All right, well, we'll check in with it. Like, I'm not gonna press. I just leave it open, like, so I can return to it, because once you get a sense of them, then you know how far you can push them. If you work with a doctor a long enough time, then that conversation was real different. Because then you can say, okay, I need to holler at you in a second. So that right there, do you know what that is? That's because you want what you want. It's not going to happen. So you need to change your position around that. Right? Now, I can't come at somebody like that when I just met them. I'm new on staff. I'm like, actually, you're doing that all wrong. Here's what you should do. I might not have a job. Right? So it's all about the same way you would join with a family.